Welcome to the Deep Dive. We're here to cut through the dense material in healthcare education and give you the core knowledge you need, fast. Today, we're tackling something fundamental, often overlooked until it isn't working right. Urinary elimination. It sounds basic, but when it's compromised, wow, it impacts everything. Dignity, comfort, life, our mission. To give you a shortcut, we've gone through Chapter 46 of Potter, Perry, Stockert, and Hall's Fundamentals of Nursing, the 11th edition, and pulled out the absolute must-knows for you. We're talking practical application, real examples, and the kind of critical thinking you need for practice and, yeah, for the NCLEX too. And to anchor all this, meet Mrs. Grayson. She's 65, getting ready for retirement, has type 2 diabetes, just got over a UTI, and now, well, she leaks urine when she sneezes, laughs, coughs, exercises. She notices dribbling sometimes too and thinks her recent weight gain might be part of it. She's the patient of Carly, a new grad nurse. And throughout this deep dive, she's your patient too. We'll link everything back to her. Okay, let's dive in. Before Carly, or you, can really help someone like Mrs. Grayson, we've got to understand how this system is supposed to work. What are the key parts, and what do they do?
That's exactly the right place to start. Think of it like a super efficient, coordinated plumbing and filtration system. You've got four main players: kidneys, ureters, bladder, and urethra. So the kidneys, these guys are tucked away in your back, kind of unsung heroes. Inside them are millions of tiny filters called nephrons, and within those, the glomerulus. That's where the blood gets cleaned up. Water, waste products like urea, electrolytes, they get filtered out. But here's something really important. Big things like protein molecules and blood cells, they normally don't get through.
So Carly sees protein or blood in Mrs. Grayson's urine sample. That's a major red flag, right?
Exactly. It signals something's wrong with the filter. But kidneys do more than just filter. They're regulating blood pressure via the renin-angiotensin system. They make erythropoietin, which tells your body to make red blood cells, and they even activate vitamin D.
Wow, okay. So kidney problems really ripple outwards.
They absolutely do. Now, after the kidneys filter, the urine travels down the ureters. These are just narrow tubes, one from each kidney, heading to the bladder. They use these little rhythmic muscle contractions, peristalsis, to push the urine along in spurts, and they connect to the bladder in a clever way.
How so?
Well, when the bladder contracts to empty, it actually squeezes the ends of the ureters shut. This prevents urine from flowing backward up into the kidneys.
Which is crucial, I imagine. You don't want urine backing up.
Definitely not. That can cause infections and kidney damage, hydronephrosis if it's blocked. Then you have the bladder. It's this hollow muscular sac that's incredibly stretchy. It typically holds about 400 to 600 milliliters before you feel that strong urge to void. For Mrs. Grayson, age might be reducing that capacity a bit, making the urgency hit sooner.
Okay, 400 to 600 milliliter, that's quite a bit.
Yeah.
And the final stop?
The urethra. That's the tube leading from the bladder out of the body. It passes through pelvic floor muscles and has an external sphincter that gives us voluntary control. And here's a really practical point, especially regarding Mrs. Grayson's UTI history. The female urethra is much shorter, only about 3 to 4 centimeters.
Compared to the male urethra.
Which is more like 18 to 20 centimeters. That shorter distance in women makes it way easier for bacteria, often from the perineal area, to reach the bladder and cause a UTI. Big risk factor.
Got it. Good to know. And maybe quickly define some key terms we might hear.
Sure. Micturition, that's just the fancy word for urinating or voiding. If Mrs. Grayson says she has dysuria, she means it's painful or difficult to urinate. Hematuria is blood in the urine. Proteinuria is protein. Both things Carly would need to investigate. And bacteria just means bacteria are present in the urine.
Okay, clear framework. But you know, it feels like this system is so finely tuned. What kind of everyday things, or maybe even unexpected conditions, can throw it off balance for our patients?
Oh, that's a great question, because it's usually a mix of factors. Growth and development is a big one. Kids gain control, usually between 18 to 24 months. But as we age, like with Mrs. Grayson, bladder capacity can decrease. The bladder muscle might get a bit more irritable, leading to more urgency and frequency. And older adults often can't delay voiding as easily.
And chronic conditions probably add to that.
Absolutely. Things like arthritis making it hard to move, or dementia affecting awareness, plus medications, they all stack up and increase the risk for incontinence in older adults. Then there are sociocultural factors. Think about privacy needs for toileting. Cultural or gender norms might influence who someone feels comfortable having assist them. Even just not having adequate breaks at work can affect voiding habits.
Right. And psychological stuff, does that play a role?
Surprisingly big role. Anxiety or stress can increase urgency and frequency, or sometimes it makes it hard to relax enough to empty the bladder fully. Depression can even reduce someone's motivation to manage continence.
Interesting. And fluids? Obviously, intake matters, but
Yes.
is it more nuanced?
It is. More fluid intake generally means more urine, assuming electrolytes are balanced. But what you drink matters. Alcohol actually suppresses antidiuretic hormones, so you make more urine. And common irritants like caffeine, artificial sweeteners, spicy foods, they can directly irritate the bladder lining, triggering contractions, urgency, and frequency. Things Mrs. Grayson might need to consider.
Okay. What about actual diseases?
Well, pathological conditions have direct effects. Diabetes, MS, stroke, they can mess with nerve control of the bladder. Arthritis, Parkinson's, dementia, they interfere with getting to the toilet.
Mobility issues, yeah.
Exactly. Spinal cord injuries can cause loss of control. And for men, an enlarged prostate, BPH, is a classic cause of blockage and retention.
Surgery, too. I remember hearing about post-op issues.
Yes, surgical procedures, especially in the lower abdomen or pelvis, can cause temporary trauma or swelling. And importantly, anesthetic and analgesic drugs often decrease the sensation of bladder fullness and the ability to empty, leading to retention right after surgery.
And specific medications.
Definitely. Diuretics are obvious, they increase urine output, but others, like some anticholinergics used for various conditions, can actually cause retention. Hypnotics or sedatives might make someone less aware of the urge, and some meds change urine color. Phenazopyridine for UTI pain turns it bright orange. Riboflavin makes it bright yellow. Good to warn patients.
And even diagnostic tests.
Yeah, things like a cystoscopy where they look inside the bladder. It can cause temporary irritation, maybe some dysuria or slight hematuria afterwards. And any instrumentation increases infection risk.
Okay, so a lot can impact this system. Bringing it back to Mrs. Grayson and her symptoms, what are the common problems Carly and all nurses really need to be able to spot and manage?
Right, let's zero in on the common alterations. First is urinary retention. Basically, the bladder isn't emptying completely, or maybe not at all. If it happens suddenly, acutely, the patient feels intense pressure, discomfort, maybe pain over their pubic bone. They might be restless, sweaty. Sometimes, paradoxically, they might be voiding frequently, but only tiny amounts. That's often overflow incontinence because the bladder is just too full.
So how do you know how much is left?
We measure the postvoid residual, or PVR, usually with a portable bladder scanner, which is not invasive, or sometimes by doing a quick in and out catheterization right after they void. A high PVR confirms retention.
Okay, and UTIs. We touched on them, but they're so common.
Incredibly common. Urinary tract infections are actually the 5th most common healthcare-associated infection, often linked to catheters or other procedures. E. coli from the gut is the usual culprit.
And risk factors besides being female.
Catheters are huge. Any urinary retention, incontinence itself, both urinary and fecal, and poor perineal hygiene increase risk. Symptoms are often that classic burning dysuria, regency, frequency, maybe cloudy or foul-smelling urine, sometimes suprapubic tenderness.
But you mentioned older adults are different.
Critically different sometimes. For someone like Mrs. Grayson, a UTI might show up as sudden confusion, delirium, maybe new functional decline, loss of appetite, fatigue, even a fall. Not the typical urinary symptoms. You have to be vigilant.
That's a vital takeaway. And the catheter issue UTIs.
Yes, catheter-associated UTIs. This is a major focus in hospitals. As you said, CMS considers them a never event, meaning hospitals often don't get reimbursed for treating them if they occurred during the stay.
So the focus shifted dramatically.
Entirely. From treatment to intense prevention. This means strict protocols, training staff, obsessive hand hygiene, meticulous technique during insertion, using a closed drainage system, securing the catheter, ensuring unobstructed flow, and getting that catheter out the second it's not medically necessary.
Huge emphasis on prevention. Makes sense. Now, Mrs. Grayson's main complaint, urinary incontinence.
Right. UI is just defined as any involuntary loss of urine. But the type matters hugely for treatment. Carly needs to figure out what's going on with Mrs. Grayson. Her leaking with coughing, sneezing, laughing, exercise, that classic symptom points strongly to stress urinary incontinence. It's usually due to weakened pelvic floor muscles or a weak urethral sphincter. Common after childbirth with obesity, fits Mrs. Grayson's picture.
Okay, that's one type. What are others?
There's urge incontinence. That's when you get a sudden, intense urge to go and you just can't hold it before reaching the toilet, often linked to an overactive bladder.
Different mechanism entirely.
Completely. Then there's the overflow incontinence we mentioned with retention. The bladder's too full and urine just dribbles out. And functional incontinence. This is when the urinary tract itself might be fine, but the person can't get to the toilet due to external factors, mobility problems, confusion, maybe environmental barriers like side rails or caregiver not responding fast enough.
So the problem isn't the plumbing, it's getting to the plumbing.
Exactly. And sometimes people have mixed UI, often a combination of stress and urge symptoms. You also hear about transient incontinence, which is temporary and caused by something reversible like a UTI, delirium, certain meds, or even constipation.
And briefly, what are urinary diversions?
These are surgical procedures, usually done if the bladder is removed, maybe for cancer. They create a new way for urine to exit the body. Some are continent, like an internal pouch the patient catheterizes themselves. Others, like an ileal conduit, involve bringing a piece of intestine to the abdominal wall to create a stoma, and urine drains continuously into an external pouch. Requires different care.
Okay, that covers the main challenges. So Carly has all this potential information. How does she actually use the nursing process to put it all together for Mrs. Grayson?
Great question. The nursing process is the framework. It starts, always, with assessment. And the most important part of assessment is seeing it through the patient's eyes. Carly needs to understand Mrs. Grayson's perspective. What does she think the problem is? What are her goals, her fears? It's a sensitive topic, so approaching it professionally, ensuring confidentiality is key.
Building that trust.
Absolutely. Then Carly gathers the nursing history. She'll ask detailed questions about Mrs. Grayson's usual voiding patterns, frequency, timing, any nocturia, waking at night to void. She'll zero in on the symptoms, the leakage with exertion, the dribbling, what makes it worse, what, if anything, makes it better, how is it impacting her life, her retirement plans. Carly also needs to assess Mrs. Grayson's self-care ability. Can she manage hygiene? Does she need help getting to the toilet? And consider cultural factors. Does she need privacy? Does gender of the caregiver matter to her?
Then the hands-on part.
Right, the physical assessment, focused on the urinary system. Carly might gently palpate Mrs. Grayson's lower abdomen to check for bladder distension. Does it feel firm or full above the pubic bone? A bladder scanner is great here if available. She'd also assess the skin in the perineal area, especially with incontinence, looking for redness or breakdown from moisture. And, if appropriate and needed, a very sensitive inspection of the external genitalia and urethral meatus for any abnormalities.
And checking the urine itself.
Crucial. Assessment of urine. Observing the color. Is it pale straw, amber, or dark? Is it bloody? Hematuria. Bright red suggests lower tract bleeding. Dark red or brownish suggests higher up, like the kidneys. Clarity. Is it clear or cloudy? Cloudy urine can indicate infection. Bacteria, WBCs. Odor. A strong ammonia smell might just mean concentrated urine, but a foul odor often signals a UTI.
And measuring.
Yes, intake and output, INO. This is fundamental. It helps evaluate hydration, kidney function, and bladder emptying using a graduated container, a urine hat in the toilet, or a urometer on a catheter bag. The key number to watch. If urine output drops below 30 milliliters per hour for more than 2 hours, that's a worry. Needs investigation.
What about lab tests?
Carly needs to know how to collect specimens properly. A routine urinalysis requires a clean sample. A clean catch midstream specimen is common. The patient starts voiding, stops, collects the middle part of the stream in a sterile cup, then finishes. This minimizes contamination.
Need to explain that cleaning process carefully.
Definitely. Specific cleaning wipes and technique for both males and females. If there's a catheter, you get a sterile specimen from the sampling port using a syringe, never from the drainage bag. The urinalysis itself tells you so much pH, specific gravity, concentration, whether there's protein, glucose, ketones, blood cells, bacteria. It's a powerful diagnostic snapshot.
Okay, assessment done. Now pulling it all together.
Diagnosis and planning. Carly looks at all the data for Mrs. Grayson, the leakage with exertion, the history of pregnancies, the type 2 diabetes, the obesity, the dribbling. Her priority nursing diagnosis is clearly stress incontinence of urine, and the related to factor is likely weakened pelvic muscles. She might also identify risk for impaired skin integrity due to the moisture, and maybe lack of knowledge about managing it.
And those related to factors guide the plan.
Precisely. Then Carly sets goals with Mrs. Grayson. They need to be patient-centered, realistic, measurable, like Mrs. Grayson will report fewer leakage episodes within 6 weeks, or Mrs. Grayson will demonstrate correct technique for pelvic floor exercises.
And planning often involves collaboration. Maybe referring Mrs. Grayson to a pelvic floor physical therapist or a continence specialist nurse.
Love that structured approach. So, plans in place. What are the key evidence-based interventions Carly and our listeners will actually do? Right, implementation. A lot starts with health promotion and patient education. For Mrs. Grayson, this includes talking about adequate hydration, maybe 68 glasses of water daily, spread out, not limiting fluids because of incontinence that can make urine concentrated and irritating.
Or maybe limiting before bed.
Yes, avoiding large amounts maybe 2 hours before bed can help with nocturia. Also, teaching good voiding habits. Taking time, not straining, trying to empty completely, maybe addressing constipation as that can worsen UI, and reinforcing UTI prevention like front-to-back wiping.
What about promoting normal urination patterns?
Key things are ensuring privacy, responding quickly to calls for assistance, and using things like raised toilet seats or grab bars if needed for safe access. For Mrs. Grayson, thinking about position squatting slightly can help women empty more fully. Sometimes techniques like double voiding help void, wait a few minutes, try again, or timed voiding going on a schedule rather than waiting for the urge.
Okay. What about more acute interventions, like catheters? Safety must be huge there.
Paramount. We talked about UTI prevention. Remember, urinary catheterization is invasive and carries risk. Use only when necessary, smallest size possible, sterile technique for insertion, maintain that closed system, secure it well, and remove it ASAP.
What are the different types?
You have intermittent catheters, single lumen, in and out for emptying, indwelling Foley catheters, double lumen, one for drainage, one for the balloon to hold it in place, and sometimes triple lumen catheters, used for continuous bladder irrigation, like after prostate surgery.
And sizes.
Measured on the French of our scale. Adults are usually 14 or 16, Faliar. Larger sizes might be needed if there's blood clots. Balloon size is usually 5 milliliters for adults, filled with sterile water.
And the safety tip about not pretesting the balloon.
Critical reminder, it's no longer recommended. Just insert gently and inflate once you see urine return. For routine catheter care, it's about regular perineal hygiene with soap and water, especially after bowel movements, and emptying the drainage bag when it's about half full to prevent pulling.
Are there alternatives to urethral catheters?
Yes. For men with UI, an external catheter or condom catheter is a great option. It's non-invasive, lower UTI risk. Application involves cleaning the penis, leaving a small space at the tip, and rolling the sheath on, securing it gently with the built-in adhesive or special straps, never regular tape. There's also suprapubic catheterization, where a tube is inserted surgically through the abdominal wall directly into the bladder, needs regular site care.
Good options. What about non-surgical treatments for UI, like Mrs. Grayson's?
This is where continuing and restorative care comes in, often focusing on behavioral therapies, usually the first line of attack. Lifestyle changes can help. Avoiding bladder irritants like caffeine or artificial sweeteners, managing constipation,
And the exercises.
pelvic floor muscle training, PFMT, or Kegel exercises. Super important for stress incontinence like Mrs. Grayson has, but also helps with urge and mixed UI. The trick is identifying the right muscles.
How do you teach that?
You can tell patients to imagine they're trying to stop the flow of urine midstream or trying to stop passing gas. They should feel a squeeze and lift sensation. For men, they might see the base of the penis move slightly. Once they identify the muscles, the routine is usually doing both quick flicks, squeeze and release rapidly, and sustained contractions. Squeeze, hold for maybe 5-10 seconds, relax. Aim for sets of these several times a day. Consistency is key. It takes weeks to build strength.
Makes sense. Any other behavioral things?
Bladder retraining is great for urge incontinence. It involves resisting or suppressing the urge for a bit, using distraction or quick pelvic muscle flex, and gradually increasing the time between voids. Requires motivation. Toileting schedules, like timed voiding, fixed schedule, or habit training based on their usual pattern, can really help manage incontinence, especially in older adults or those with cognitive impairment, using prompted voiding with caregiver help. And don't forget skin care. Protecting the skin from moisture is vital if incontinence occurs, using barrier creams, keeping skin clean and dry. Incontinence is not a normal part of aging, and skin breakdown is preventable.
It's a comprehensive toolkit. So after implementing these interventions from Mrs. Grayson, how do you know it's working?
Evaluation is that crucial final step. And again, the best source is the patient. Carly needs to talk to Mrs. Grayson. How does she feel things are going? Assess the impact on her self-image, her confidence, her willingness to go out and socialize. Is she less worried about accidents? That's a huge outcome.
Beyond the subjective feelings.
You compare the patient's actual progress to the goals you set. Carly would ask Mrs. Grayson about the frequency of leakage. Maybe have her keep a bladder diary for a few days. Is she able to hold urine longer? Is she doing her Kegels? Carly would observe Mrs. Grayson's technique if she taught her something like self-catheterization or exercises. And importantly, she needs to reinforce that progress might be gradual.
Especially with things like Kegels.
Yeah.
Takes time.
Exactly. It's not an overnight fix. Carly needs to evaluate Mrs. Grayson's understanding of the plan, her ability to manage at home, and offer continued encouragement and support, adjusting the plan if needed.
This really highlights how nursing care integrates science, skill, and that crucial human connection. It raises a final thought. How can nurses, and you listening, keep advocating for the best care in this area? It affects so many people. What should spark your curiosity moving forward? We've really dug deep into urinary elimination today, from the body's amazing system to the hands-on, compassionate care you'll provide. Remember, getting a handle on this isn't just about exams. It's about restoring dignity, comfort, and control for your patients.
Absolutely. Think about how understanding all these pieces, the anatomy, the physiology, the risks like UTIs, the behavioral strategies, allows you to make a profound difference in someone's quality of life. Managing elimination is fundamental. You have real power here.
Thank you so much for joining us for this deep dive. We hope it gave you a clear map, some practical tools, and maybe a few aha moments to take into your studies and future practice.
Keep learning, keep asking questions, and know that you're making a difference.
This has been The Deep Dive. We're so glad to have you as part of our learning community. Stay curious.